health systems should have a process to identify patients at risk for thromboembolic disease. Having that process to identify the patient, they should also have a process then to anticoagulate those patients with the appropriate anticoagulant and appropriate management team to prevent an adverse event from anticoagulating a patient. So if we have a patient that we want to anticoagulate, an adverse event is bleeding. We want to prevent a thrombus. So we need to have a team in place, an appropriate resource based off of the patient to prevent the complications of not anticoagulating or inappropriate anticoagulating or over anticoagulation. So healthcare resource utilization will vary depending on the patient's comorbidities, the patient's acceptance to a therapy we decide is most appropriate, and thirdly is what can the patient afford, which we're finding it used to be price or cost of medications when we would send surveys would be fourth or fifth on the list for patients. And we're now finding with changes in insurer processes where the burden of or the percent of payment for patients for prescriptions is much higher than it used to be. So now cost is actually number one or number two for patients where before it was much further down the list. So in choosing and looking at the economic burden, we not only have to look at it for the health system, but we have to look at the economic burden for the patient. So when we talk about transitions of care, if I'm transitioning a patient out of an institution and I know by keeping them, I'm not making any money. In fact, as an institution, I'm probably losing money. But if the patient has a high cost burden and the patient does not, so they go to the pharmacy to fill their medication, the cost is too high for them, so they do not fill the medication, they have a complication and they're readmitted, the burden is actually now on the healthcare system and also on the patient. So it's very complex. Yeah, so I think one of the important points to understand as we've moved in, we have available now for the direct-acting oral anticoagulants, is we need to look at the burden or cost burden along with disease burden. And the cost burden to patients is essentially now a very high factor or a very high consideration where before it wasn't. So with the direct-acting oral anticoagulants, they're very expensive, and the pharmaceutical companies have rebate or coupon programs. Some of those are good for several months, some are good for a year, but then what happens? And we have to be cognizant that if we want patients to remain adherent to therapies, we as payers, we as caregivers need to make sure we're picking the most appropriate medication for the patient. So we may have a patient that does not want to be monitored on warfarin, but nor can they afford the cost burden of the direct-acting oral anticoagulants. So we have to have that discussion with the patients to say they're almost equal. The direct-acting oral anticoagulants have shown a lower incidence, lower incidence of intracranial hemorrhage by about 1%. But when we put that in front of a patient, so having the discussion with the patient saying, this is the therapy I'd recommend for you, this is the cost. Here's a therapy because you said you didn't want to come into blood work, and this is the cost. And let the patient decide so the patient stays adherent to the therapy. If the patient's not adherent, it doesn't matter what we give them. So cost for adherence is very important.